If you are watching this is part two of the conversation that we had, and the link for part one is somewhere around on the sides here or in the description. So I would recommend that you watch that first. The next thing is wound care.
Oh my.
In the United States, for whatever reason, I do not understand it, how wound care is in our Practice Act. And you don't do any wound care.
Nope.
Yeah, so wound care, it's not commonly done by physical therapists anymore, but I have done wound care. I've done wound care several times. I've primarily done jet lavage. I've never done sharp debridement, and that would petrify me to do. I would not feel comfortable doing that. I have done jet lavage a number of times, and yeah, you don't do wound care ever.
I do. I personally do burn patient treatment, but only outpatient. So my role is to increase the range of motion and to increase the elasticity of the skin. And most of the time the patient's skin is already closed, so there's no real wounds. But sometimes it arrives that he has wounds, but I'm talking about maximum this big. So I just put some cream and a little plaster. No, what you?
A dressing?
No, not a dressing. What did you put on your toe the other day?
A band-aid?
A bandage. I just put some cream and bandage on those small wounds, and it's all.
Yeah, I like to call it a water gun. It's not a water gun, but I squirt the wound and remove the necrotic tissue, the slot.
No.
And you have to measure it. And
oh my, no. I had
it's
once,
not that bad.
As a respiratory physical therapist, some nurses are so disgusted because I remove secretion from the patient's lungs, and I find this so interesting, and I can't see a wound on the sacral region because it's so big and so deep, and how can you even live with that? Oh no, I'm out of here, bye, I'm going. No, not once.
Okay.
Ugh.
The next thing I think is going to be so complicated for us to talk about, I don't even know if I'm going to be able to keep this in here, is how you guys measure your productivity for a day. So if you go on any board on Facebook or Reddit or any other website where you see these physical therapists talking, almost everybody in the United States is complaining about the productivity requirements and how it is becoming unrealistic within the United States. And I think, like, I've tried to talk to Chris about it before, and I think we really just struggle because we have two different systems, and it's so hard for, like, me to understand his system and him to understand my system. So see if I can break it down. I don't know. I'm going to his job tomorrow, so I might get a better picture actually being there. But this might confuse you.
Okay.
It's complicated. In the United States, the way we measure productivity, so when we bill our patients, it is for treatments, not for evaluations and not for wound care, it's a time-based code. So you bill a certain number of units in your day, and one unit is approximately 15 minutes. And if you go by Medicare, it's the 8-minute rule. So if you see a patient from 8 to 22 minutes, you bill 1 unit. If you see them from 23 to 37 minutes, it's 2 units. And then at the end of the day, you have all your units. And depending on how many hours you've worked, you need to bill a certain number of units.
Okay.
So to kind of put things simple, like, and nobody works, well, some people work 4-hour days, but most people don't work 4-hour days. But say you worked a 4-hour day, and so if you did 4 units an hour, if you build 16 units for the day, you would have 100% productivity. But especially in a hospital, that would be impossible because you have to chart review the patients, you have to find the patients, you have to find the nurse, you have to hope the patient's in the room, you have to hope they agree to do therapy, you have a whole list of things that can go wrong as to why you might have all this time where you're not billing for direct patient care, because you can't bill for the chart review, you can't bill for running between the 7 floors of your hospital and Mr. Smith is in dialysis again and whatever. And so it depends on the hospital. But some hospitals have a very high productivity. Like some hospitals expect you to maintain 100% productivity, which I don't understand. I don't comprehend how that is possible because just there's so much that goes on in a hospital. So some more realistic ones are like 75% productivity. And evaluations are different. And that's also, I didn't realize different hospital systems do it differently of how many units they weigh. You don't bill it more units, but it's how the amount of like credit they give you for measuring your productivity. And so I don't know, are you like understanding?
It's hard, but I do understand, and it's really hard to
so
imagine
hard.
because here it's so much easier. For inpatient, you just pay according to the pathology. It's a pack. Like let's say you broke your hip, you need a hip replacement with a prosthesis. So in that case you need a surgery with this amount of medication, with a prosthesis, with this amount of bandage, with this amount of physical therapy, with this amount of, I don't know, and their estimation are for a hip prosthesis you need like 7 days of hospitalization. After that you can be discharged. So during those 7 days the patient should have physical therapy every day. But in the real life, we can't always have that. Like we're mostly understaffed and having more and more patients, and sometimes when the patient is alright and already walks alone, does the stairs alone, we don't go see him. But it's still included in the pack that he's having, but we don't see it because we don't have the time for it. But on the other hand, if you have a patient that has another pathology like a COPD problem, where he needs only once physiotherapy a day because his pathology includes that, if we see that it's not enough, we'll do more. So it's just we choose about how we use our time for that patient. For some patient, I just do 10 minutes. It won't change the amount of money that the hospital will gain. But for other patient, we do 45 minutes because you just took a little more time. But the insurance and the packs are like simple physiotherapy is 30 minutes. Complex physiotherapy is 45 minutes. After that, do what you want.
So, the sad thing is, it's pretty much the same thing in the US.
Yeah.
You get a package of how much money the insurance is going to give the hospital. But the hospital doesn't care. Their reimbursement does not change. If I treated a patient except for in rehab is different, but in acute care, if I treated a patient for 60 minutes versus 10 minutes, the hospital doesn't make any difference. But my boss might look at me differently as to how much time I spent in direct patient care. And I have personally never experienced this, but I have read horror stories on the internet of, they call them like the book of shame. So, or even they make list of the therapists that if they don't meet the percentage of required productivity, they have to write the reason as to why they didn't meet their productivity.
Well, here well, in my hospital, my boss doesn't care. Well, as long as the job is done, and I don't need to write down how much time I did it for real. So I just do my own way. So if I consider that the patient has enough physiotherapy today, I just go to the next one. But I don't write, he just made 15 minutes because he was tired. I don't do that. I just write what I did, like get out of the bed, walked this amount, did this exercise, and that's it. And it doesn't change anything, and I don't have to write down how the real time I had with that patient. Because maybe tomorrow I will do a little bit more with this one and a little bit less with another one. So I'm more flexible on this.
Yeah, it's different.
It's
So
hard.
I guess, and another thing too, you document every day
Yeah.
your treatments. And how long would you say it takes you to write a treatment note?
I'm lazy. And it depends. If it's something really big like a stroke where you have to make an assessment on every function, everything, it takes me about 10 to 20 minutes. If it's just like an old grandmother who fell on the floor at home and she's still walking, I just do like 2 minutes, just write down, got out of the bed, walked, balance training, that's it.
And then do you have to justify your services?
No.
So, and again, this is probably more outpatient, but I did have this experience as inpatient. Sometimes we have to include in our notes as to why the insurance should still be covering physical therapy. So we have to say, like, in order to prevent a fall, and something that's becoming even bigger in that, well, something that I've experienced is becoming bigger is they want to use tests and measures. So there's certain tests that will predict your fall risk. And so you can use that as evidence-based practice that they scored this on this certain test, they're at a high fall risk, and this is why they should have PT. And then you can use that same measure as your continuing therapy and saying, therapy's working because they scored this at the start of treatment, and now they scored this, and they met the minimal detectable change, and they're doing better, so keep paying for my therapy service because the patient has a less fall risk.
As I told you, physiotherapy is in the basic insurance. So basically it will always be paid. But there's might be the difference that in acute care, you might sometimes have to justify if its rehab center is really needed. And we can do some tests and have a score, but sometimes it's just not possible. Like, I don't know if you know the TINITY test. So it's not possible to do a TINITY test if you cannot, if you need to hold the patient all the time.
Yeah.
That's not possible. So I just write my note, scoring not possible because it's too dangerous to let go the patient. It's enough, and the doctor's okay, and he goes to he writes to insurance and says that patient can't go home right now, still needs physiotherapy, and has to go to a rehab center. And that's it. After that, in the rehab center, they're still doing some physiotherapy in order to put the the patient back home. And sometimes we can still give the patient more physical therapy at home, because he can work, he can go home. There's still something to improve, but he doesn't need to be hospitalized for it. So he gets home with like 9 sessions of physical therapy, and that's it. But the insurance will always pay.
Yeah, sometimes the insurance will go back and deny payment. So you already treated the patient and they won't cover it afterwards.
What?
Happens with doctor visits too.
Oh, fuck.
If you didn't do the proper authorization,
No way.
yep,
Well,
they'll deny the care.
we have sometimes
You just lose the
prescription
money.
we have sometimes prescription where it is not even a diagnostic, but just show the pain, So it can be anything, but
We have the same thing.
but the insurance, it's okay with it. It's written by a doctor that the patient needs physical therapy, so they'll pay,
Yeah.
and they can't deny it.
And that, again, it really varies based off what insurance company the
Yeah.
patient has. But some of them are a little more picky than others. Okay, so the next thing is the use of gait belts. So in inpatient, my experience in inpatient has always been you put a gait belt on every single patient, because if that patient fell, like if they tripped over something in the hallway that you weren't expecting them to trip over and they fell, and you don't have a gait belt on, and they go and they sue the hospital or they sue you, and the hospital looks back and says, did you do every single thing possible to prevent this fall? Was the patient wearing a gait belt? And if you say no, the patient was not wearing a gait belt, you did not do everything possible to prevent this fall. So I put a gait belt on every single patient. Well, some traumatic brain injuries would adamantly refuse a gait belt, which in case you would have to document patients agitated and is refusing a gait belt. Or, I mean, some of them, even if they're not a brain injury, they still refuse, but you have to document they're refusing a gait belt, and that's why you didn't use it. So I think there are some states where gait belts are illegal, though, but I'm not completely sure on that. But in my experience, I've always used a gait belt on every patient.
I never heard about a gait belt until she talked about it, and I still don't see the use of it, because if the patient trips, is gonna fall. It's not the belt that's gonna prevent it. It's like I don't know. I don't understand the concept of a gait belt. I'd rather hold my patient on the thoracic axillary region, because I can accompany the patient on the floor, because my hands on his waist I cannot hold him, and he will make me fall. So I don't understand how it works.
But
I don't know.
I will admit, I primarily use a gait belt to help me with transfers. So if you have a total assist transfer, especially if they don't have pants, if they like to wear their little sundresses and there's nothing to grip on except for maybe a diaper that you're ripping, gait belts can be amazing. Like if you can position them properly, and it really gives you something to hold on to help assist the patient with transferring. I have had incidents of where I was with a patient, well, we were gait training, and the patient's knee buckled, and I was able to grab them midair and get them back to standing. Because falling is a very bad thing in the hospital because of reimbursement and Medicare and a bunch of stuff. So if a patient falls, it's really, the hospitals try to do everything to prevent a fall. Even if it's an assisted fall, even like if you helped lower them down to the ground so they didn't get injured, it's still a fall. So
for us too. As soon as the patient touches the ground, it's considered as a fall.
But yeah, I do agree sometimes with gait belts, especially if it's like a larger patient. Even if they had a belt on, are you going to be able to hold them up and regain their balance?
Well,
realistically, probably not.
We're in Switzerland, so large patient.
They're not as large as my patients.
When I see a large patient, it's not that large a comparison for you. So in that case, we go. If there's a risk, we go with 2 PTs for one patient. And honestly, the only patient that fell with me, I didn't understand what happened, because he was totally fine walking alone. He could have been at home, it would be exactly the same, and he missed the last step of the stairs, which is the only fall I had with a patient, and I wasn't even touching him, and he would have missed the stair alone at home will be the same. So even without the gait belt, our patient doesn't fall. Sorry. For the transferred, I just grab their butts.
But there's nothing. I really do actually. I love it when patients have pants and not slippy pants.
Yeah.
It's so much easier to transfer with pants, and I know I give a lot of patients wedgies, but the belts, especially if it's a patient who is very flaccid and has very poor trunk control, and you have to do what I call pop over transfer, and the patient's like falling over. There's a certain way that I position the belt that really helps with getting them over to the chair.
Well, I mostly do like bobette transfers, if you know the bobette concept.
I know the bobette.
So,
I don't remember.
well, I do a lot of bobette transfers if the patient's having trouble with muscles. And if he is really weak, we use the sling to make it to get into the chair, and we do mostly then after sitting exercises, and otherwise we take the standing device to make the patient stand and gain some strength. And we won't force a transfer. It's if there's a risk that the patient falls or that we get hurt.
And we're moving to that in the US as well. I'm pretty sure across the country. I know in my experience of where I've worked, we're using a lot more equipment to prevent both injury to the staff and injury to the patients, but it's been almost a hard mentality to change because we're so used to just moving the patients ourselves. But we do have a lot of equipment that can work on challenging their standing, and that you can use like for walking and stuff, that they're strapped into a piece of equipment so they're not going to fall, and you can have your hands more on other areas rather than holding them up. And I mean, yeah, that's going to vary a lot by facility. I know me being in an inpatient rehab, I had a lot more equipment than somebody who is in an acute care hospital might have. But it depends what the hospital wants to buy as far as equipment.
And it depends also on the mission of the hospital. Like, you won't have some machine if you have just one patient a year that will require that machine.
Yeah.
So, in my establishment, we have some mature equipment, but there could be more, but don't have money for it.
So, the last planned topic is physical therapy assistants. So, PTAs, physical therapy assistants, it is a thing that exists in the United States. It's a profession. They work under the supervision of physical therapists. And again, it varies by state as to what amount of supervision is required by the overseeing physical therapist, and because there are some things that like physical therapy assistants are not able to do that physical therapists can do, some of the more like advanced things. And physical PTAs, they don't do evaluations, they can't do reevaluations. That has to come from the supervising physical therapist. But Switzerland, PTAs don't exist.
We have a PTA at my work, but she's actually a massage therapist and does mostly, like 99% of the time, outpatient, where she does massages and lymphatic massages, and sometimes she helps us with inpatient with patient who works almost alone. So it's as we asking a nurse or a nurse assistant to make the patient walk, but otherwise they're not here. So we don't have that.
Do you have any other questions about my work in the United States? We've talked so much.
Yeah, we talked.
But there's still a lot we don't know.
I don't know.
No.
Do you have burn patients? Oh,
Yeah.
So you-
I've never done
Yeah.
it, but there are therapists that do that
That's what it's-
specialize on burn units.
And for the skin massage?
Yeah.
Oh, yeah.
Yeah.
That's great. I love it.
All right. Well, I hope you enjoyed our video about the differences between the countries. I know I've seen this commonly posted where people in the United States wonder, like, what is it like in other countries? So this is the best we can get for
Yeah.
you. It's so hard to explain because neither one of us have actually worked in the other
No.
country, so we don't have firsthand experience of being in the other country, but yeah, so that's our video. Bye!